Sorry, that would be me. I apologize, but yeah, carry on.
Okay. So I was just thinking, should I be pressing it again? Okay. So the next housekeeping announcement is on the translated caption that we have available. So for those who would like some captions, please select caption option and then turn the translation on. And you can select the speaking language, which is the presenter's language, and then my caption language, which is the translation that you prefer. All right. So I hope that that is clear, and therefore then we will now go on to the session. All right. So I think all four of our speakers are already on board. So this session is on ACT for severe mental disorders, a theoretical background and clinical experience, and it be presented by the vibrant psychiatrist from the Turkey chapter of ACBS, and they will be sharing on a summary of theoretical approaches to the psychotic and bipolar disorders, followed by experiences of individual and group psychotherapies based on ACT. So the floor is yours, all four of you. Go ahead. Thank you.
Thank you so much for the presentation. Hi, everybody. Am I host now? Okay. Welcome to our presentation organized by ACBS Turkey chapter. My name is Sevinç. I'm a psychiatrist and I'm currently working as a researcher in Can Sağlığı Foundation Center for Contextual Behavior Science. I'm studying with trauma in addition to severe mental disorders. My colleagues Denizhan, Merve, and Şengül are also psychiatrists, and in this presentation, we will address the challenges and varying perspectives related to diagnosing and treating patients with affective and psychotic symptoms. In addition, we will share our experiences of group act with both bipolar and psychotic symptoms. I have no permission to share, I think. I don't know what.
Yep, you should have permission. You could share now.
I will check. It's okay now, I think. Yep. Schizophrenia and bipolar disorder represent two forms of severe psychiatric conditions. Perhaps the most controversial area of psychiatric nosology is the distinction between bipolar and psychosis, and I will begin with diagnostic systems and their associated critics. The first dichotomic classification belonged to Kraepelin. He defined the classification of dementia praecox and manic depressive insanity. The argument on the validity of classifications of psychosis and manic states started immediately after this definition and persists to present day. With the examination of Kraepelin's original case summaries, criticism of dichotomist classification system also came to light. When assessed in terms of prevalence, some argue that there is a higher incidence of manic depression in clinical settings than anticipated. Also, significant overlap was found in a study between dementia praecox and bipolar disorder. Kraepelin challenged his own dichotomy in 1920s and emphasized the significance of understanding structure of illness rather than arranging them in orderly, well-defined groups. The current diagnostic system based on DSM-5 is categorical. Regarding psychotic disorders and affective disorders, there are three main diagnostic categories: schizophrenia, bipolar disorder. and schizoaffective disorder, which is often treated as a diagnosis of exclusion and disregarded from research. Despite the potential utility of categorical diagnosis, the reality of difference between bipolar and schizophrenia has been one of the biggest debates in the nosology. The use of technologies such as molecular biology, genetics, and neuroimaging to investigate disorders raises the question of how useful these categorical classification systems are in understanding the etiologies of these disorders. A number of studies have been conducted on the basis of this question. Genetic studies show a partial common genetic etiology for schizophrenia and bipolar disorder. Family studies and twin studies have shown that both disorders aggregate in families. Neuropharmacological mechanisms and response rates to atypical antipsychotic treatments are similar. From a neural point of view, many brain alterations previously shown in schizophrenia have also been found in bipolar disorder. And another challenge, hallucinations and delusional beliefs are the core aspects of schizophrenia, but these symptoms are frequently observed also in bipolar disorder, especially during manic episodes. There are some challenges also in clinical settings. Patients often do not fit completely within the boundaries of a single disorder, and many patients show a mixture of clinical manifestations associated with schizophrenia and bipolar disorder. Distinguishing which symptoms constitute a bipolar and which are related with abnormalities of personality can be also challenging. One of the situations also we usually encountered as psychiatrists, although the patient was initially diagnosed with bipolar disorder in their medical records, for example, 10 years ago, it's evident from the latest examination that they now meet the criteria for schizophrenia. Diagnosis can change. Also, research has demonstrated that subthreshold states, which do not fit into any categorical classification, cause psychological impairment. Why do we place so much emphasis on diagnosis? To have a condition labeled as a disease may bring, of course, benefit, but the diagnosis of a disease may also create problems. A diagnosis may lead to patients regarding themselves as defective and unable to rise above their problem. This can be a challenge for treatment adherence. When diagnosis focuses on symptoms, psychological research may become more connected to symptom management rather than the underlying mechanisms responsible for them. The incomplete identification of potential psychological processes as risk factors also hinders interventions to prevent the disease. The symptom-oriented nature of the diagnosis can lead treatment to primarily target symptom reduction based on medical model. However, literature reports indicate that patients in remission in terms of symptoms have impaired functioning. This pattern is also observed in the subthreshold group. In fact, for many years, this perspective has led to a focus on pharmacological treatment and neglect of psychosocial interventions. One another problem is comorbidity. For example, the literature has demonstrated that individuals with bipolar disorder and the history of trauma may experience remission after PTSD treatment. This raises the question of whether patients should take medication for life. When to stop medication is questionable. Of course, there are potential benefits of categorical diagnosis, but the challenges I have mentioned have led researchers to explore a new model of understanding severe mental disorders, and the continuum model has come to the fore. There are two possible, valid, and empirically studied interpretations to term continuum. One of them is psychosis continuum. It refers to the idea that psychotic symptoms such as delusions, hallucinations exist in a continuum ranging from normality to pathology. Schizophrenia bipolar axis model range between the prototype bipolar disorder and the prototype schizophrenia. This can be an explanation for mixed symptoms. Psychosis continuum has a wide range of areas such as positive symptoms, affective symptoms, anxiety symptoms, and situations that cause impairment in social and vocational functioning. The continuum model appears to offer a resolution to the diagnostic problems. One of the most evidence-supported psychological approaches in bipolar disorder is the stress diathesis model. According to this model, patients with bipolar disorder exhibit a hypersensitive behavioral activation system and increased reward responsivity as a vulnerability factor. The encounter of behavioral activation system relevant stimuli or disruptions in social rhythms may trigger initial symptoms of mood elevation. Another approach to understand the development of bipolar disorder involves explaining bipolar spectrum disorders within the context of unipolar depression model. Depression avoidance hypotheses include two propositions. One of them is vulnerability to manic states is connected to psychological processes that promote depressive tendencies. Manic states arise as a consequence of strategies developed to avoid negative affect. There are two approaches within this category. Psychoanalytic approach, one of them, and another one is a response-based theory developed by Hoeksema, which is rooted in the concept of depressive rumination. There are two primary studies grounded in the response-based theory that explain mania and hypomania. Thomas and Bentel proposed that individuals with bipolar disorder use coping strategies such as distraction and risk-taking behaviors to reduce depressive symptoms. But these strategies have a risk of triggering mania and hypomania. As you can observe, this hypothesis implies the presence of prodromal symptoms. Depressive symptoms are necessary to trigger a manic episode. It may be inadequate to explain cases with only manic episodes. CBT is most studied and usually considered as the gold standard of psychosocial interventions for treating psychiatric disorders. CBT model of bipolar disorder proposed that alterations in mood and cognitive processes, starting with, again, depression and mania, influence behavior. These behavioral responses, in turn, amplify the intensity of distorted cognitive processes and emotional states. The main goal of CBT for bipolar disorder is to maximize adherence with treatment and relapse prevention, and techniques for identifying and managing early symptoms is an important step in therapy process. CBT is associated with fewer hospitalizations, reduced relapse and severity, but there are some limitations. Some patients with bipolar disorder remain symptomatic and do not achieve sustained periods of remission. Despite symptomatic recovery, some patients continue to experience residual mood symptoms, and they can lead to the recurrence of mood symptoms. Patients with a more chronic course, for example, more mood episodes, may not benefit from CBT. Comorbidity is another problem because it's higher in bipolar disorder, especially axis 1 disorders. And you should apply separate protocols if you are treating with CBT. When treatment is overly focused on reducing symptoms, the consideration of functionality also can be neglected. Mindfulness-based therapies have gained attention aimed at addressing these limitations. Mindfulness-based cognitive therapy is the most studied one for bipolar disorder. It's effective in the treatment of depression and especially comorbid anxiety disorders. However, long-term outcomes regarding manic symptoms are inconsistent. ACT can be a promising approach to overcome these limitations. Because it's transdiagnostic, it's consistent with continuum hypothesis, and it eliminates the need for separate protocols for comorbid conditions. And because it's value-oriented, it's inclusive for residual symptoms, and improving functionality is one of the main objectives. The study is mostly focused on experiential avoidance. There are relatively fewer studies examining the effectiveness of ACT. I know two of them in the literature. They focused on especially comorbid conditions like suicidal ideation and anxiety. I want to finish my presentation. I think we can take the questions at the end of the presentation, and I want to invite Enver Denizhan Ramakan for sharing his experience on bipolar disorder group ACT. Denizhan Ramakan is working as a psychiatrist in Bakırköy Research and Training Hospital for Psychiatry, Neurology and Neurosurgery. He is working especially on bipolar disorder, but also language and behavior, RFD. And you can start, Denizhan.
Thank you for the presentation. Thank you for that insightful presentation also. Oops, sorry. Now I think you all can all see.
Sí.
You know that I'm Denizhan Ramakan, like Sevinç Ulusoy also. I work in Bakırköy Research and Training Hospital for Neurology and Psychiatry. Now I'll talk about the practical part of the psychotherapy with bipolar disorder. I'll share our group experience. Presentation is going to last about 12 to 13 minutes, I hope so. First, we can talk about what did we do. We wanted to work with bipolar disorder and prepared an ACT-oriented protocol in line with this purpose. We have worked together with Sevinç Ulusoy and conducted these groups in Bakırköy Research and Training Hospital. We have conducted 6 groups. One of them was pilot group. All group processes consisted of 6 sessions. Each session took about 2 hours, and groups consisted of 6 to 10 participants. Participants were outpatients. They were all on medication and they were all in remission. We have designed this protocol as well-being groups. Bipolar group is a neglected group in terms of psychotherapy. Clinicians see treatment as just pharmacotherapy and psychoeducation. In our clinic, lots of our outpatients ask about psychotherapy. And we know that it's not enough just being in the euthymic mood for people with bipolar disorder. Euthymia refers to stable and healthy mood, not being depressed or not being in mania. Even in this healthy euthymic mood, they have impaired functionality in most of life areas. And beside that, sometimes pharmacotherapy can't be enough to protect person from these mood episodes. Stressful life events may trigger these mood episodes. We see it a lot, unfortunately. Most therapeutic methods for bipolar disorder include psychoeducation, and most of them don't work with self-processes. Most of these people have major attachment to their patient self-label. It has a negative impact on people's lives. Considering all this, we took such a path. First, we have checked previous studies, previous X studies about severe mental disorders. There are some studies about psychosis and 2 bipolar disorder group studies. We have reviewed the protocols of these studies and prepared an ACT-oriented group therapy protocol. Then we have tested this protocol with a pilot group. We have changed the protocol in response to feedback. We have shortened mindfulness at work, and we gave more time to values. We saw that diffusion was hard to understand and to abstract in the first protocol. So we made some changes and additions. In pilot protocol, we wanted to decrease self-stigma, so we didn't give space for mania and depression especially. we talked about them though. In participants' feedback, they wanted to learn more about their episodes, so we gave more time for these. These are our sessions. I'll talk about them shortly. Session 1 starts with meeting and explaining the rationale of this therapy process. Then we invite participants to grounding exercise to improve present moment awareness and getting back to here and now in difficult situations. Every session starts with grounding exercise, and this exercise given to them as homework. Then we ask each participant what the struggles they are experiencing are, how this disorder affects their life, and which areas they cannot take a step. We can move toward to exploring values from this exploration of struggles. Then we introduce the metaphor of passengers on the bus, which is a great metaphor for groups. It includes all 6 processes of psychological flexibility. This metaphor is the skeleton of the whole therapy process. In session 2, we work with thoughts via passengers on the bus metaphor and my mind says that metaphor exercise, and they choose a valued action to do between sessions. In session 3, we work for creative hopelessness and then improve acceptance ability via physicalization of emotion, and they choose a valued action to do between sessions. Session 4 consists of sense of self-worth. We explore participants' self-labels as broken, ill, unstable, inadequate, unlovable, etc. Also, these self-contents are passengers. Then we work on self as context, and again they choose a valued action to do between sessions. In session 5, we talk about depressive symptoms, their thoughts, feelings, and dysfunctional actions, their behavioral tendencies. Then we want from each individual to create a character made up of all of these things. What this character says to do, what does client do when this depression character talks, what do they desire to do from now on. In our last session, we talked about manic symptoms. What do they experience while manic episode was coming, their thoughts, feelings, and dysfunctional actions. Then we want from each individual to create a character made up of all of these. What this character says to do, what does client do when this manic character talks, what do they desire to do from now on. There are some outcomes we have observed after therapy. First, it was surprising for the participants that we didn't do psychoeducation, and there were some objections about that. But since ACT processes are transdiagnostic, and after they start to get these processes, they were pleased about the situation. One of our goals about not doing psychoeducation was reducing self-stigmatization, since they already know about bipolar disorder. In the sessions, we asked them what they experience about this disorder or in the mood episodes, so they also see that each one is unique and also others experience similar things too. It helps to provide normalization in a genuine way, I think. We observed that their valued actions are increased, not just homework. A number of them perform way more than homeworks. Experiential avoidance scores decreased. Also, functionality we have observed increased. We also observed a strong attachment to self-labels or self-as content as bipolar, ill, etc. We saw that they are afraid of having an episode again, rightly, and they really worry about it. They do not contact what they value not to risk their health. so they become living for avoiding episodes, not for things they value in life. We have also observed experiential avoidance as an example in some risky times of theirs. They told about how did they took risks to not to be depressed anymore. We have observed something wrong with presentation. Sorry about the problem.
This is where the times where our own skills are being tested.
Right. Okay. You can see now, I think. Most of bipolar patients use more than one medication. A number of them experience side effects that affect their life. They can bring these to therapy, and these side effects are important contextual factors that have impact on their behaviors. Another difficulty was that some clients used the grounding exercise for experiential avoidance, even though it was emphasized that this was not the case. It would be good to be careful about this. In-group conflicts were another challenge. It's in the nature of the group events. Thankfully, we had very few encounters. Conflicts were solved after we encouraged them to take perspective, and they realized every person's experience is unique. And there are participants who have a lot to tell. It would be good to inform the group at the beginning about we might interrupt them nicely for practical reasons, which are limited time. Other participants need to talk and getting off the topic. It made therapy process more understandable to use fewer, simpler, and inclusive metaphors. Reframing medication or avoiding episodes as a valued action, not just professional says so. It helps them taking their own decision, feel and live less dependent. Group format helps normalizations, and also seeing every person's pain is different. Grounding, bus metaphors, self-labels, and episode characters were most memorable things in the process. How could it be better, and what to do in the future? Self-labels and self-stigmatizations are important and common problems with these clients. These processes get our way in every session and become an obstacle in sessions and in their lives. So it might be better to work with sense of self in early sessions. Might be good to increase the number of sessions, adding sessions about how to handle things in difficult or stressful times, about what do they do to avoid from episodes and why do they do those things might be good. We talk about these things in sessions, but giving more time might be useful. And if you have any opinions or contributions, you can ask after presentations. This is my contacts addresses if you want to. Okay, thank you.
Thank you to Denizhan for being open to sharing your experience with us. And I want to invite Merve Terzioğlu for presentation of theoretical background of psychosis. Merve Terzioğlu is also a psychiatrist. She's working as a researcher in Can Sağlığı Foundation Center for Contextual Behavior Science. She's working especially with psychosis and also experience sampling methodology. And Merve.
Thank you, Sevinç, for your presentation. I am sorry about my voice. I have a cold these days, but I think I can handle for 10 minutes. You can't see my screen.
Not yet.
Okay. I think now there isn't problem. Okay. And I'm going to talk about theoretical background of psychosis, and then Şengül share her experience with an ACT group therapy with psychosis. And psychosis is a complex phenomenon characterized by a range of symptoms that includes cognitive, emotional, perceptual, and behavioral symptoms. And the illness model of psychosis has been dominant throughout the last century and primarily focused on schizophrenia as an illness. And the notion was that mental illness is an illness like any other medical illness. And first, Kraepelin used dementia praecox, the concept of dementia praecox, and it includes in its name pessimism about the chances of recovery. And then Bleuler first used the concept of schizophrenia. So throughout the much of the past century, it was the central organizing concept around which theories of severe psychiatric symptoms were constructed. However, the concept of schizophrenia has faced so many criticism because this concept combines symptoms that are so heterogeneous and that two individuals with the same diagnosis may have no symptoms in common. You know, a patient with disorganized schizophrenia is so different from a patient with paranoid schizophrenia. And additionally, the boundaries between schizophrenia and other diagnoses, such as bipolar disorder, are subject to debate. So it is really schizophrenia is an illness, and we ask two questions according to this. Is the diagnosis of schizophrenia reliable, or is it a valid construct? And reliability is the degree to which different clinicians will agree upon a diagnosis in any given case. We know that diagnosis of schizophrenia has low reliability. Even experienced clinicians who have been given extra training in applying the criteria only agree on a broad diagnostic category about 50% of the time. And is schizophrenia a scientifically valid construct? In fact, if it's not reliable, validity is meaningless. But if we explore validity of schizophrenia, we see that we should show that it must be shown to be related to symptomatology, prognosis, etiology, and treatment. It should be useful in terms of understanding or predicting anything. So in terms of symptomatology, if it's a valid construct, it should be a set of symptoms that occur together but not in other mental illnesses. However, there is no empirical evidence supporting the existence of a distinct set of behaviors and experiences specific to schizophrenia, and that do not manifest in other psychiatric conditions. And in fact, in a study, it has been shown that individuals diagnosed with dissociative identity disorder exhibited a higher prevalence of schizophrenic symptoms than those diagnosed with schizophrenia. And in terms of prognosis, if it's a valid construct, it should have a predictable outcome. But there's no evidence that people with psychosis have a common prognosis. And there are huge variations in outcomes. And so it has very little predictive validity. And we know that DSM is neutral with respect to theories of etiology. So this diagnosis says nothing according to etiology. And it should predict a response to treatment if it's a valid construct. But we know that it fails to predict response to treatment because responsiveness to medical treatment is so heterogeneous among psychotic patients. And so we see that schizophrenia is not a useful scientific category anymore, according to four validity areas. And Benthal says that for all these years, researchers have been pursuing a gauge within the body of psychiatry. And we can say that and some people, but we know that some people have experiences that are very unusual or difficult to understand and suffer extreme distress and confusion. And how we will approach these experiences. There has been some alternative approaches for that. And one of them is a single psychosis syndrome. It suggests a single psychosis syndrome that encompasses the categories of schizophrenia, schizoaffective disorder, and bipolar disorder. And another alternative approach advocates for dimensional models, which consider variations in symptoms along multiple dimensions rather than rigid categories. Because statistic analysis suggests the existence of a psychosis syndrome with variation between patients on 5 dimensions: positive symptoms, negative symptoms, symptoms of cognitive disorganization, depression, and mania. And this approach is supported by the idea of phenomenological continuum between psychotic symptoms like hallucination and delusions and normal mental states. As Sevinç mentioned, a continuum model supports this approach, and emphasizing dimensions over categories, recognizing that both normal and abnormal human behaviors, thoughts, and feelings vary over time and across social contexts. And a further approach makes minimal assumptions about the structure of mental illness and attempts to explain the actual experiences and complaints of psychiatric patients. So it just focuses on specific phenomena such as auditory verbal hallucinations and paranoid beliefs. And this paradigmatic shift has led to significant progress in understanding psychotic phenomena. There is a huge literature on persecutory delusions, and it shed light on many issues about psychosis. Now we will get into details in terms of etiology and treatment of psychosis. Schizophrenia, they taught us in medicine faculty and our psychiatric residency that schizophrenia is a biological based illness. And for the past 50 decades, it has been claimed that the brains of schizophrenic are abnormal. So it's a disease of the brain, and there's a genetic predisposition to schizophrenia. So it's biological. But is it real? What is the literature supporting these assumptions? When we look at the dopamine hypothesis, we know in 1590s chlorpromazine has been discovered, and because these drugs block the dopamine system, it has been thought that schizophrenia must be overactivity of the dopamine system, and it has been considered as a fact. But now, when we look at the literature, we see that few studies have provided convincing evidence of altered dopaminergic activity. New neuroimaging techniques had found no significant differences in dopamine receptor density. Although the dopamine hypothesis has been the prevailing hypothesis for decades, dopamine function in human post-mortem studies has not been forthcoming. And so biological psychiatrists looked for another neurotransmitters like GABA, glutamate, acetylcholine, but there is not much to support these in psychopathology too. And when it comes to brain abnormalities, we know that psychotic patients have enlarged ventricles and cerebral atrophy. It has been showed many times, but is it the etiology of the disease, or is it consequence? Now the studies show that there is a substantial overlap between the schizophrenic population and the control population, and it's not these are not specific to psychosis. They have been found in many other disorders such as depression and alcoholism and traumatic history also. And yeah, we know that early childhood trauma can cause ventricular enlargement, cerebral atrophy, and dysfunction of the limbic system. And also antipsychotic medication can cause ventricular enlargement and cerebral atrophy too. And when it comes to genetic predisposition, the consensus in psychiatry was that schizophrenia is caused by an inherited genetic predisposition in combination with environmental events or triggers. It's called the diathesis stress theory. And the most frequently cited evidence in support of genetic predisposition theory, it comes from family, twin, and adoption studies. And so scientists searched for schizophrenia gens, but this attempt has also failed. There is no specific gen for schizophrenia, and the available evidence provides little, if any, support for a genetic basis for schizophrenia. So there's not been much progress in the realm of biological psychiatry. On the other hand, the role of emotions, trauma, and environmental factors in the development of psychosis have been explored. And we know that poverty is related to schizophrenia, and it's called that one of the most consistent findings in the field of psychiatric epidemiology. And we know urbanicity is related to psychosis. Studies demonstrate a correlation between urban living and psychosis, and the connection between social class and psychosis is most pronounced in urban environments. And it has been repeatedly demonstrated that ethnic minorities are significantly more likely to be diagnosed with schizophrenia than members of the dominant culture. And the idea that bad things can happen and can drive you crazy is not controversial to public, but it was controversial to mental health professionals. But now it has substantial empiric support. In a meta-analysis which focused on sexual abuse, physical abuse, emotional abuse, neglect, bullying, and parental death, it has been found that people who had suffered childhood adversity were 2.8 times more likely to develop psychosis than were those who had not. And even a dose-response relationship has been found with traumatic events and psychotic symptoms. and they have all been related to psychosis. And also family interactions like express emotion, affective style, communication device were also related to relapse and onset of psychosis. And other social factors have a causal role in or they are significant risk factors for psychosis, like mother's health, nutrition, stress during pregnancy, and an unwanted pregnancy, etc. And we know negative emotions, emotion regulation strategies, cognitive biases, and theory of mind have all shown to be related to psychotic symptoms. They have been found in formation and maintenance. They've been found effective in both formation and maintenance of psychotic symptoms. And when it comes to medical treatment, guidelines recommend treating psychosis with antipsychotics. Even placebo controls has been forbidden. It has been called unethical use of placebo controls for psychosis. Yes, we know that antipsychotics effective, but nowadays evidence is accumulating that their benefits have been overestimated and adverse effects are underestimated. And they don't seem to be as effective that we thought, because around 1 to 20% of people with perceived difficulties will experience a benefit that can be attributed to drugs, and data are too limited to assess outcomes from initial antipsychotic medication treatment for individuals with an early episode of schizophrenia. And we know that all antipsychotics may increase mortality due to their effects on physical health. And there's been medication-free research started, and now the ethical prohibition on medication-free research has been lifted, and they say that psychological treatments might be effective for people who refuse antipsychotics, and service users want more than just drugs, and psychosocial treatments appear to be highly acceptable. And Thomas Insel recently concluded that psychosocial treatments for psychosis are powerful yet woefully underused. So now it is there is an option. Not we don't have to just use antipsychotics for psychotic symptoms. We can use another methods, and patient choice may be introduced. We know that CBT is effective at latest NICE protocols, and it has been recommended that everyone diagnosed with schizophrenia should have a CBT minimum 6 months and 16 sessions, individual psychotherapy, and third wave CBT are also effective. And at the latest research, the latest research support of acceptance and community therapy in psychosis is modest research support, and because ACT is transdiagnostic, and it's the new approach to psychosis is so convenient with ACT, so it may be it seems to be effective for psychosis. And we know And conclude, I think I should finish. The theoretical background of psychosis encompasses various approaches, including social, psychological, and biological perspectives. Understanding the complex interplay between these factors is crucial for developing new approaches. However, further research is needed to fully understand the effects of these interventions on psychotic symptoms and to optimize treatment outcomes, and it seems to be an effective intervention for psychosis. Now, Şengül is share her experience with you. Thank you.
And special thanks to Merve for this inspiring presentation, especially considering her unwell state. And now I want to invite Şengül İlkay. She is a psychiatrist. She's also working as a researcher in Can Sağlığı Foundation Center for Contextual Behavior Science. She is also working with suicidal patients, and she will be presenting her experience with group ACT therapy with psychosis. Şengül.
Thank you, Sevinç. I need to share my slides. Yeah. Could you see my presentation? Okay.
Yes.
Hello, everyone. I'm going to share our experience with group ACT for psychosis. As Merve said, current evidence shows that ACT may be an effective treatment option for psychosis. ACT has over 1,000 randomized controlled trials on different topics. At least 9 of them are about psychosis. It has begun to be included in international treatment guidelines. My colleague and I conducted this group therapy protocols while I was working at a training and research hospital in Aksaray. At the same time, my colleagues was working at the community mental health center. During our visits, we identified the need for an additional intervention for psychotic patients who had treatment resistance. As a result, we decided to make an ACT intervention for those patients at the community mental health center. The center has almost 800 patients. All the patients were taking medication. We used ACT for Life protocol from Joseph Oliver, Eric Morris, and their team. The protocol has 4 sessions, and each session is 2 hours. Middle of every session has 1 break for 5 minutes. We applied the protocol after translating it from English to Turkish. The protocol is structured on the metaphor of passenger on a bus. It's a useful metaphor for group work because it includes 6 processes of psychological flexibility. Every sessions begin with a mindfulness exercises and then continue with the introduction and discussion of the passenger on the bus metaphor. Then we clarified the values of patient. After that, cognitive diffusion exercise was applied. At the end of the session, committed action planning was made for each patient, guided by their values for between session practice. We made 4 groups with a total number of 32 patients. We planned 10 members of each group, but some patients dropped out. Some patients didn't want to move on the therapy. And some of their family members didn't want them to continue to this group because they worry about finances. changing the balance in family relationships, or worse, the patient. In the first two groups, the protocol was applied identically. At the end of group sessions, we got feedback from patients, and we also had some observations about experiences of the patient. Both patient and clinician indicated that the number of sessions was insufficient. Based on our observations, planning for value-oriented behavior proved to be particularly challenging for patients who had a long duration of psychosis. Another important observation was that more repetition was needed to achieve behavior change. According to our clinical experience, self-stigmatization was a serious obstacle, self-as content issue. I have schizophrenia, I can't do anything, I am sick, useless, weak, etc. For improving psychological skills. In light of these group experiences, the next two groups were continued with revision to the protocol. We added two more sessions and added new exercises about acceptance of emotions and sense of self. After completing the group session, we observed changes in the patient's behavior, and these changes serve to improve their functionality, such as socially, family, or work area. Here is my team. We have some photos about our experience. Thank you very much. It's a quick presentation.
And thanks, Şengül, for sharing your experiences. I think we have only 2 minutes for questions. If you have any questions, we can take, or maybe we can share our email.
I think just a quick comment in the sense that I think a number of psychiatrists are actually very interested in the stuff that you've been doing. And I think they will be in contact with you all very quickly, very soon, to find out more about what you all have been doing, because it's a very interesting work.
Thank you so much.
Is there any
Uh,
questions? Yes, I see someone raising their hands. Would you like to speak up? You can unmute yourself and ask the question directly.
Hola,
Hi.
soy mexicana. Me pareció muy interesante ver esta presentación porque aquí en México no se ha visto llevar a cabo esta terapia en este tipo de pacientes. Sería muy interesante poderlo llevar a cabo.
So I'm not sure whether the translation came true, but basically she said that it would be very interesting that this is being carried out over also in Mexico. Am I right, Andrea?
No lo alcancé a leer. Ah, No se entendió lo que dijeron.
Very sorry, Andrea. I think we're having a communication issue here. We can't quite
Yep.
understand.
Okay, I think Andrea probably will try to get your questions in written probably. All right, my apologies for some of the technical issues right here with the language. But with that, actually our time is up. We're already at the 2 o'clock hour, so I think I'll pass back the session to Eugene. But before that, thank you so much once again to all four of you for the very interesting sharing, and we will probably be keeping in touch with all of you soon. So back to you, Eugene.
All right. Thank you very much. We'll move on very quickly to our next presentation. And I think our next speaker is someone that we don't actually need much introduction. So prior to housekeeping, for some who just joined us, you can actually turn on the caption by clicking the translation. And I do understand that we have a large number of Spanish speaking participants, so you could use the captions. It is not the best, but it works as much as we could work with it. So without further ado, I would like just to invite our next speaker, who is going to talk about the implications of idionomic assessment for diverse population. Our speaker is actually none other than Stephen Hayes himself. I believe this is someone I don't actually even need to introduce too much. He is well established, he's well known in our society, and he's here to tell us today about what's new, especially when it comes to the up and coming ideas about idionomic assessment. And I hope I did not butcher too much the introduction, Stephen Hayes. So I'll just pass it off to you then.
Very good. So is my microphone working? Can you hear me okay?
Loud and clear.
Very, very good. Well, so I'm going to mostly do this without slides. I'll jump over a little bit, maybe. And thank you for inviting me. I'm very pleased to be here and to have heard the last talk, which was fun to listen to. And thank you for that presentation. And what I want to reflect on is the psychological flexibility model and ACT and this 40-year journey that it's been on of developing an intervention approach. But it's been on a larger journey than that. From the beginning, the work on acceptance and commitment therapy or training, ACT in either case, has been driven by an interest in processes of change. One way you can show that is that while the first workshop was 41 years ago in Broughton, North Carolina in 1982, the first book on these methods was in 1999. Not quite 20 years later, but almost. The first randomized trial was 1986, and then the next one, and then there was one in 1989, which I wasn't involved with. The next one I was involved with was in 2002 or 2001. So why such a long gap? It's not because we are lazy and not doing any work, but because what we wanted to do was to dig down to the smallest set of principles that would do the most good for the most people in the most areas. The first 4 or 5 studies on ACT were on a wide variety of things. In those early to mid 80s, there was a study with depression, there was a study on pain, there was a study on diet and weight loss. And that kind of breadth has continued throughout, and I will describe some of those things in my talk. in that long 20-year period when we're not publishing very much in the way of outcome studies, we're developing measures of these processes. We're doing basic studies on language and cognition and why they would lead to these processes, why internal rules that you may come up with or may have heard from others tend to dominate over our experience. Why the stories that we tell about who we are and how we should be dominate often our deeper sense, you might say more spiritual sense of self that connects us in consciousness with others. Now, probably for most folks, this is familiar territory. You've heard that kind of story. There's a few things you might not know that are relevant to the title of my talk today. You might not know, for example, in the early to mid 80s, we did qualitative research, one at a time, with entire transcripts of ACT sessions, trying to identify what we saw in the talk of clients over time with the early ACT protocols, and what we saw in the betweenness, the connection, the interconnection, the relationship between therapists and clients in those early days. It's a little funny to look at it now because we're talking about 5 or 6 or 7 graduate students working with maybe 20 clients, but entire dissertations done on one client with very careful and intensive analysis. Durya Karakiwala, for example, one of my earliest graduate students, did this with a set of sessions in some of the early ACT work. Why does that matter? Well, the research that was going on was very small and idiographic research on, for example, how rules dominate or how we can soften the impact of verbal rules. What we saw verbally, what we actually saw and how people talked about their own experience in line by line coding of therapy transcripts using qualitative research methods. If you take something like the AAQ, the first measure of psychological flexibility, it took so long to develop that its story has never been fully told, and so few people were interested, and so many things were done over many years that it's really hard to fully lay out that story, and maybe that's a little sloppy of us, but I can tell you that these early qualitative, idiographic, one person at a time studies moved right over into the self-report items that eventually became the AAQ. Now, the AAQ has some criticisms, but there's now 100 different measures of psychological flexibility. Even if you put aside all the research on the AAQ, it's still the most commonly studied process of change in all of clinical psychology. So ACT doesn't stand or fall on the history of the AAQ, but what I'm saying is the principles that are inside the psychological flexibility model were from the beginning designed not to be normative and categorical, but to fit with the personal experience of clients one at a time, and done in a way that didn't ride roughshod, an English idiom, but it didn't treat as unimportant the details of the particular people who we were working with. Well, now here we are, 42 years later. And we don't have, when I said the third wave of CBT had arrived in 2004, we had 6 randomized trials. There's now 1,054 on the website. And I have a list of about another 40 to post with the staff at ACBS. We'll be passing 1,100 randomized trials very soon. There's a new one every 3 or 4 days. And there's some things that are very characteristic about this that I'm pleased about and that relate to the lower middle income country focus of this wonderful 24-hour event that you've put together and the Developing Nations Committee has put together. If you look at those 1,050 or so randomized trials done, you will find that there are about 480, something like that, that are not in journals that are indexed in the Web of Science. They don't have an impact factor. And we have critics who say, oh, see how weak the research is. Putting aside the fact that we have something like 170 randomized trials in journals of impact factors of 7 or higher, including some really wonderful ones done by the World Health Organization, by major scientific groups. When we look at those 482 studies, 402 are published in lower and middle income countries. Look, here's what the fact is when you look at evidence-based therapy. Evidence-based therapy has been dominated by the 12% of the world's population who live in Western, educated, industrialized, rich, democratic, well, we'll see how democratic, but still maybe in general, democratic countries. That 12% of the world's population produces 88% of the published scientific work that is indexed in our big indexing engines. And the citation patterns are even worse. So how can we get to a situation in which this very odd, of course, WEIRD, the Western, educated, industrialized, rich, democratic, are set up to spell the English word weird, and it's quite true. Why should the weird be the metric of how human beings function and prosper around the world? And the answer is, of course, they shouldn't. They shouldn't. It is a kind of cultural domination, a kind of classism, racism. You name your ism that's sort of built into our scientific community, and that I'm proud of the fact that ACT and ACBS has done its work. I know how many hundreds and hundreds of hours we have spent. And I will say, I myself count some of those hundreds, working with the staff to dig into indexing engines that are around the world from particular nations and language communities to make sure that every study that we can find, whether the results are positive or negative, are on that list that you can access on the website. That's something to be proud of, and something to really take seriously, because the kinds of questions that are asked in those studies are very, very important to the arc of human well-being around the world. I'll give you an example. There's more studies in that list of studies coming from lower middle income countries on ACT, on how to integrate ACT processes and principles with faith traditions and religious traditions than any other section of work? Well, a large percent of the human population care about these traditions. And the fact that perhaps the Western academic medical centers don't, and they're chasing the DSM and the illusion of latent disease models, shouldn't hold us back from considering people as whole people. And part of that wholeness includes their wisdom traditions, their cultural traditions, their spiritual traditions, their literature, their art, their poets, their musicians. It includes their culture. So how are we going to take the advantage, and I think it is an advantage, of having developed processes ideographically and trying to get to principles that are broad and are very cautious about making statements that are in principle, not general. Let me give you an example. While there's a lot of work on ACT values, measures, and so forth, there's no list of ACT values. Because as soon as you make that list, you'd be making it from your particular cultural context. We have an interest in helping our clients explore their own values in a way that fits with their history and their culture. But we shouldn't be allowing the small set of countries that have the money to do these huge randomized trials to be dictating to the rest of the world about what values should be. I'll give you another example. Sense of self in the ACT model is tied to an experience of awareness that is there to some degree even before language. This theory of mind and perspective taking skills that all humans are born with. You can show even in infants that they understand a bit about connections with others and a bit about the intentionality of others. That's just the kind of creatures that we are. But in many languages, these deictic frames are not so much I and you, they're we and they. And fortunately, by focusing on perspective taking and not by a particular form, it's not difficult to adjust the principles that are involved, the relational frame theory principles and the extension to perspective taking, that allows different language communities with different, more collectivistic, more individualistic approaches to be included. A more recent one that I think is important, while the early ACT work talked about acceptance in terms of undermining avoidance of difficult emotions, the research itself began to show that that included sometimes avoidance of so-called positive emotions. And now more recently, it includes clinging and hanging on to positive emotions as a feature of emotional inflexibility. And so acceptance as a concept has been broadened by ideas that come from different parts of the world about attachment, for example, and how positive emotions can produce a kind of rigidity, avoidance, or clinging that is also toxic to individuals' psychological flexibility. Now, in my title, I talked about idionomic assessment and its implications for the developing world, for lower middle income countries, for the 88% of the world's population that's outside of those Western European Anglophile countries. And what I want to argue with you, or argue to now, is that the movement that we've been making that is in the earliest work on qualitative research, idiographic research, small n research, processes that are broadly applicable and care about not, linking them to particular content, that inside that is a methodological idea that is now time to put into the world and will help us, I think, make the entire world's experience far more important as a scientific matter that is no longer optional, not just as a moral matter and as an issue of fairness or of the interest in the well-being of people around the world, but also as a scientific matter of understanding even how these processes work, that we need to make sure that the contextual features that are being examined include the experiences of people around the world, and that the research center move from the huge randomized trials and very well-funded academic medical centers in just a few places around the world to the experience of behavior change agents working with individuals in every corner of the globe. Let me explain what I mean, where it's going, and why I think the next 10 years is going to look quite different than what we've been seeing up to this point. Just a few things about our top-down normative categorical systems that came out of the Western academic psychiatry. The idea was if we could collect signs and symptoms into syndromes, we could then find what is the functionally important pathways that led to problems, the mechanistic course, that is the development and why it happens over time of these problems, and how they respond to treatment and why. What is are the processes that are altered by treatment, and why does that better the individuals? When you have all of those, etiology, course, and a response to treatment, a syndrome is turned into a disease. Unfortunately, in the half a century that we've spent scores of billions of dollars around the world pursuing, there's not a single example of a new psychiatric disease. Not one. But the system has gone around the world. And in every part of the world, when that system has entered, the well-being of the citizens, if it was measured before this idea took over culturally, and then after, in every area when that's happened, the overall well-being of the population has deteriorated. Not a single psychiatric disease has been identified since untreated syphilis, and that was long before the DSM. But not just that, our effect sizes, how big of an impact we have on these entities, has been flat or going down in every area. Anxiety disorders, depression, in every area. Nobody argues that we're getting better and better. Maybe we're flat, but flat is a failure for a scientific tradition. There's no other major scientific traditions that can be happy with no functionally important progress over 3 to 4 decades. And that's exactly what we're looking at. We have to do better. I think, and I've written a lot to argue, and I'm going to show you a few things here, that part of the problem is normative categories that lead to bell curves on which people are placed do not predict the trajectory of the individuals who are put on those bell curves. Everybody is told in their statistics class that they do. Almost everybody in the world now believes that they do, because for 150 years, that's been the argument. But it's based, I believe, on a mathematical error it violates an assumption of the statistical methods that allow you to go from a collective to predicting a trajectory of individuals within a collective called the ergodic theorem. I'm not going to try to unpack the ergodic theorem, but I will perhaps go ahead and show you just a little bit of some data that we've collected in the lab and what kinds of patterns we're seeing in the research that will be coming out or has come out over the last, a little bit has come out over the last little while, but more will be coming out very soon. So let's see if I can successfully share this. Those are some real data on the relationship of compassion for yourself and compassion towards others. Do you see that bar and the lines? Are you able to see it properly if somebody nods their head? Okay. Thank you, Jean. The correlation is about 0.4, 0.5. Very consistently found. If you're kinder to yourself, you're kinder to others. But you see there's lines going in the other direction. And when we actually dig into this, it turns out if you put these kind of data through our traditional statistics, even the statistics that promise we will model the individual first, they tend to show that virtually all these lines show a positive slope, but it's not true. There's about 1 out of 8 or so people there who the nicer they are to themselves, the meaner and nastier they are to others. And that's hardly a unique finding. We've looked in area after area after area, and we've seen the same thing. Here's an example of mindfulness and negative affect. In general, if you're more mindful, you have more positive affect. That's the mean. These are all individuals where we're modeling that relationship over time, day by day, with many, many data points, 40, 50 data points. And in general, when people are more mindful, more flexible in their attention, their emotional well-being is higher, but not always. There's a group of people there, the more mindful they are, the more miserable they are. And if you go in and you just say, oh, well, we're just, you have some negative emotion, or you need mindfulness training. What if you have one of these patients? And now when you calculate I squared or Q squared, 2 ways in meta-analyses that we decide whether or not, you may know if you've ever taken a meta-analysis class, when you decide whether or not you can combine studies and report the central tendency of a group of studies. There are statistics by, for example, the Cochrane report or the NICE guidelines in the UK. These, agencies like the World Health Organization and so forth that allow you to do big meta-analyses and report the overall effect. If there's too much variability between the studies looking at a same issue, you're not even allowed to report the mean. You literally can't put it in the journal article. And this statistic, the cutoff for Cochrane is 0.5. Anything above 0.5, there's too much, not just random variability, too much systematic variability, study by study, that is unexplained to make it to be scientifically legitimate to report the central tendency. What you're just seeing here, the I squared is 0.88. You wouldn't be allowed with data like that. If these were studies and not people, you would be prohibited from being able to report that nice pink line in your studies. Is that an outlier? Is that something that never happens? Well, no. When we've looked, here's another one. This is asserting my emotional needs and whether or not I feel lonely. A very common thing if you're doing relationship-oriented work with people. If you're lonely and you don't have good relationships with people, be more clear about what your emotional needs are. Allow people around you to be able to connect you with you in a way that lifts you up and empowers you. It's a good idea, but not for everybody. For most people, yes, that's true. But then there's some people for whom, and the fact that it doesn't touch that line means it's significant within the person, not between people. And again, the I-squared value is so high, you wouldn't even be allowed to report that red line if these were studies and a meta-analysis. Well, you not only report it, you dance around it like it's a maypole. That's a little dance that's in the US of A and some farm communities. We dance around and celebrate if we get those red lines to fit with our theory. But then the human beings that we're treating and that we're telling our clinicians, you know, this is what you're going to see. And when they go in the study and they see the two things that, let's say this is a comparison of CBT and interpersonal therapy with depression, and you see these nice smooth curves and you say, oh, okay, when I follow the data, that's what I'm going to see in my practice. This particular study, they measured it every single session, and here's what the actual people look like. So this is what the clinicians see. That's what the readers of journals see. It's no wonder that practicing clinicians begin to say, those journals don't fit my experience. I'm not sure that I'm being helped. Of course, your mentors, your supervisors, your universities tell you it's so important, and they wag fingers at you if you're skeptical, as if you're immoral for not genuflecting in front of normative, statistical, and methodological rules. But when we have looked at how badly we violate our statistical assumptions of ergodicity, and let me just say, it'll be a little disorienting, but in our research, when I say our, Stefan Hoffman, Joe Sorochi, Baljinder Sadra, myself, and a number of the process-based therapy people around the world, we've decided, probably stupidly, but we've decided if we're going to raise this issue, we're going to start with our own processes. So we're looking at values, we're looking at acceptance, we're looking at sense of self, we're looking at diffusion. And it's a little dangerous because people who are not too happy with ACT, may say, oh, look, see, it doesn't really apply to everybody. Yeah, put your own ideas out there and let's see how they fare. This is a hard graph to read, but what this is a statistical tool that we've come up with to look at violations of the assumption of ergodicity. The assumption of ergodicity is basically the statistical principles that are needed for you to say your position on a bell curve predicts your trajectory over time. I'll just simplify it. And it requires two things. One is that it has to be stationarity, and everybody has to follow the same dynamic model, which means basically the same mean and standard deviation over time. And we have ways of looking at that. This is just whether or not, this is not stationarity, this is just whether or not these measures, it doesn't matter what they are, but they're psychological flexibility measures. As I say, we're starting with our own. And we have a little cutoff that we violate that assumption if the chi-squared, when you look at how much individual variability there is in there that's systematic versus the overall central tendency, there's a way of doing a goodness of fit statistic, and if it's significant, then it violates your assumptions. And if you have a chi-square of 6, it's already significant. 25 would be bad. If you can see these numbers, I'll just call out a few. I'll just read a column. These are chi-square values: 183, 215, 192, 222, 185, 230. I mean, it's just massively far away from what you think you're doing. When you report those means, you think you're saying something that captures at least most people. And it's not true. In every area we've looked, virtually none of it is true. Now, there is a way to get around that. The way to get around it is to take all these individual patterns. This is yet another one, emotional well-being versus persistence and doing what you think works. Once again, almost as many people going in the opposite of what theory says. You can begin to look within the person over time without any comparison to other persons as to how these processes link to outcomes. These are data from a person. This is using a back end of a tool called MindGrapher, which is being put forth by a charitable organization I'm president of, the Institute for Better Health. If you go to www.ibh.com, you can get information about it. It's going to be released on Cyber Monday. And some of what we will release will be free. I'll even show you here in a second part of what we will release that will be free and available to all around the world. But what these are within-person correlations done properly. I won't go into the stats of how to do that, but basically you have to do vector autoregression corrected correlations. We borrowed a statistic that was common in economics. We made it apply to the individual. We call it I-ARIMAX. ARIMA is what it's called in economics, and the first validating article on ARIMA is soon to come out, we believe, we hope, in Stefan Hoffman's journal. But these are the flexibility processes, single item measures with an individual who is struggling with saying yes when she should say no. She's a hardworking person and she's got babies at home. She has family values, but if her boss asks her to do something, she often will say yes when she should say no. And then her babies go to bed without a bedtime story and she's mad. She should have said, no, that'll take a day, or that'll take 2 days. And so we had an item that we created called, I consider my legitimate needs before I say yes to the needs of others. Why? Because she wants to be there for her family and her children. And these flexibility processes that we would know as ACT people, attention to the now, acceptance diffusion, all related within her over time. This is small numbers, you probably can't see it, but that says 0.6, 0.4, 0.2. That's like a correlation, but it's corrected for slope. Because as you know, 2 positive slopes for anything will correlate, which you don't want to do when you're within the individual. Because if you do, you could easily say things like, Steve Hayes stumbling for the right word correlates with the size of his ears, which is true. Why? Because your ears never stop growing. I'm sorry, you're looking at an old man, and guess what? You know, you got big ears, and they're still growing. So does your nose, by the way. But it has nothing to do with why I'm having a harder time remembering names. They're both markers of age. Well, this corrects for all that. And this particular thing says self as context is most important, then attention to the now, values, diffusion, acceptance barely makes it. But now we use artificial intelligence methods because we have a whole bunch of data over time using a random forest procedure. The way I describe it, and I'll do it kind of as a metaphor rather than try to explain the statistics, since most people don't understand machine learning algorithms and things like random forests. They're not commonly used in behavioral science. They're very commonly used in computer science and among AI methods. These same data that assumes linearity, it's a correlation, Now we're run through what we're calling iBaruda. It's so cool. I love this thing. What it does, it takes this, in this case, the 6 flexibility processes, and we're chasing, did I consider my legitimate needs before I said yes to the needs of others? We created that item because that's what she wanted to work on. Acceptance is not significant. The other ones are. But now it's different. Values is most important. Then diffusion, attention in the now. Self as context, which was the best when you assumed linearity. When you don't. Now, what does this thing do? What it does is it takes a small set of these 6 processes, but it runs them against processes that are made up. They're called shadow variables. And basically, for each variable you want to predict to see, does this explain what's going on with my client? You create a variable that has, this is not quite right, but it's easiest way to think about it, that has the same mean and standard deviation, but the data are scrambled over time. You just randomly move around all the data. Well, that shouldn't predict anything. And what it will do, what a random forest does is basically says, can you find a value on this measure or this measure? Let's say we're testing these 2 against also some shadow variables. So let's say we're having 4 processes chase. This is done in thousands of iterations, of course. Chase whether or not you set healthy limits, said on saying no when you need to instead of yes. The fact that it's significant means it always beats the shadow variables. It doesn't have to be linear. It can be curvilinear. It could be a sine wave. It could be upside down U. It could be U-shaped. We don't know. And as clinicians, do we care? The only thing this is doing is first looking to say, in this run with this particular combination, can you sort the outcome you care about into a high and low bin significantly by looking at a particular value of each of these variables in competition with all the other ones, including the shadow variables. So here's the way I explain it. It would be like if you had 4 dogs chasing a rabbit and you ran that race 3,000 times. Each of the 4 times you ran it, you got 2 dogs from your 6 variables you care about and 2 dogs who are made up dogs. They're pretend dogs, they're shadow dogs. They're artificial dogs. The dog that catches the rabbit gets a point, and then you run the race again with random samples. You run it thousands of times. So the one that best sorts into high and low is the top of the branch. And then you look at those 2 buckets and you say, and within that top bucket or in that bottom bucket of outcomes, can I sort them into high and low? And if so, you add another branch. So you're building a tree, and it's called a random forest because you build thousands of trees. That's what you're looking at here. Now, back to my dog metaphor. Maybe that dog caught the rabbit because it's fast. Maybe that dog caught the rabbit because it's mean and the other dogs get afraid and run away. Maybe it caught the rabbit because it smells so bad because it was sprayed out by a skunk that the other dogs run away and they don't catch the rabbit. This is a metaphor for, maybe values are only important when you have a certain level of emotional acceptance, because when you connect with your values, if you hurt where you care, maybe you don't want to know what your values are. It's too painful. So you don't make any assumptions about distribution. You can look at interactions. But now that you've got this, these 5 are significant. And we've done simulation studies, basically almost no type 1 errors. If it says it's related, it's related. It could make a type 2, but frankly, clinicians don't care about that. We're not model testing here. Just don't lie to me, statisticians. Please don't lie to me. If it's important, I want to know it. Make it simple. Okay, so we'll build one more tree. And here's Elizabeth, the person who I worked with, her actual tree. When did the babies go to bed without a bedtime story? About 1 day out of 5, 17% of the time. And how did it happen? When on that day, she was hooked by her thoughts and her diffusion skills were below a 64. And on that day, her connection with her values were below a 62. But if it was above 64 and her values were above 75, so doing something that's maybe kind of hard on a 1 to 100 scale, her ability to say no when she needs to instead of accidentally saying yes was much higher, more than double on the other days. Do you understand what this shows? Think of it this way. Best day, notice your thoughts with some diffusion skills, stay true to your values, you're good. Get hooked by your thoughts, sort of start forgetting your values, you're in trouble. Well, but then you can do what I did is, well, what about values? You know, what is the crucial thing? And we did a structural equation modeling showing that of the two, values was predicting diffusion more than diffusion picking values. Now, what this comes out of a thing called gimme, which I can't explain here because it takes too long. And I want to save a little bit of time for questions. But given that, I'm going to look at values especially, and I'm going to ask this question. What are the actual behaviors that predict when she maintains her values? Now, why would you want to do that? Because even if she gets hooked by her thoughts, as long as her values are kind of clear, she's okay. I mean, even down here where she's hooked by her thoughts, she's at 55 versus 75, but she's not down there at 35, which is where the babies go to bed without a bedtime story. Does that make sense? And the overall network using this other statistical idionomic method that I don't have time to explain here, but I have, and this app that I'm talking about will do this, not at launch, but a few months later. It's already doing in the back end. So now I'm going to look to see, well, what predicts values? When do you stay in touch with your values? And here's what we found. This is yet another thing where we did first something like that, then we did a decision tree, but now this is a different decision tree. When are you in touch with your values? Well, if you don't feel stuck and unable to change, that's a good idea. And when you're helping your health at a very high level, it was 85 on a 1/100 scale, then you're really down with your values. If you're feeling stuck, then you're in trouble. Well, I get on stage with this gal and I say, look, you're already doing something that will keep your values really high. And if your values are really high, no matter what happens, you're going to be okay. But it has to be high. It's up 80. You don't have the numbers here, but it says very high. It was 85 on a scale of 1 to 100. I said, what the heck are you doing? You've already got success going on here. She says, I have a yoga practice. It takes an hour to do. I sometimes skip it. But if I don't skip it, I'm fine. If I do skip it, everything goes cattywampus. An English phrase meaning upside down. Yeah. So the whole session turns in how to keep your yoga practice going. I would never have gotten to that just by going in and listening to her complaint or by applying the psychological flexibility model. I needed to reach into her 24/7 world and know what actually happened to her. It won't come from words like depression, anxiety disorder. It comes from life as it's lived. And this 40-year arc of starting with process data and qualitative data and ideographic data and experiments with 3 people in them that are doing geeky relational frame theory studies, all of that has set up a place where the point of this entirely too slow talk can now be made. I want to argue that why idionomic assessment, and you're beginning to see what's coming. You're seeing what it's going to look like when these apps that I've been working on for 10 years and intensively for 3, when some of these new statistics that as a team we've been working on, when they're released and easily available to you, what it will allow you to do is to not have to use culture, language, community, religious orientation, and without asking your clients, just come up with an idea of, oh, therefore, this person will care about this or care about that or be this way or that. Yes, you need to know that cultural information in order to ask good questions. Yes. But each person has to be seen. I have a book by my bedside table that was given to me by the head of the Persian chapter of ACBS, ALIC2023, on the myth of the Islamic world, of just walking through how much variability is in the Islamic world. And this one category that most Western people have, if they don't know anything about Islam, is very false. Yeah, the scriptural texts are there. I also try to read the Holy Quran and understand why ACT is popular there in Persia. But my point being, let's find out from the people that we serve what are their particular ways that they think about, feel about, care about, or act with regard to their relationships, their family, their emotions, their jobs, their children, their community. So allow each voice to be heard. Instead of thinking that we can continue with these abstractions in randomized trials from 12% of the world's population. Okay, well, what if it was from the entire world's population? It still rides over the details of the persons that we're dealing with and turns them into an error term. The standard deviations that we apply in our traditional methods are variability between people. The work that we do clinically is trajectories and empowerment and variability within person. That's different. The statistics have to be different. The measures have to be different. And so the reason why I care so much about taking ACT in a process-based direction that has a modern face of idionomic statistics and finding a way finally to be able to put this in people's hands, not just with very nice but kind of complicated books like that. You try to do those networks, it's very burdensome. We can do networks things now in such a slick way, you know, almost immediately in 5 minutes have the computer create networks for us. So we just feed it a little bit of information. I was going to show you that back end, but the clock tells me I have only 5 or 8 minutes. So that's why I think it matters. We are heading to an era in which you as an individual practitioner will be able to do very important work just in your practice or in a small agency or community or hospital around the world, have high density longitudinal data that really allows every human story to be told, every voice to be listened to, and no one ever being turned into an error term. And when we get there, the focus, and I don't think it's very far away. Some of these things we're releasing on Cyber Monday take us very close, I think, to where we need to be. First, put out most in English, although some of the apps are language neutral. But when that happens, the focus of our development will need to shift to how we understand and can target and change the particular processes of change that are relevant. The psychological flexibility model does an awesome job. You need to expand it a little with things like not just emotional avoidance, but also emotional attachment. And you need to care about the social level and about taking care of your body. So it isn't all just psychology, it's also your body, and it's also your family, your relationships, your community, your nation, the world. And I think that gives us a way of learning from lower and middle income countries without saying to them, we will only listen to you when you have multi-million-dollar grants that frankly cannot give us the data we really need, and that can only be mounted in a small portion of the world. So that's my talk. I'm sorry for going so long. I hope you find something interesting there and inspiring. If you want to follow me, you can go to stephenchayes.com and I will tell you more about when these things are released. I don't spam people. You do have to read English, but just my name.com. Click on yes, please send it to me, and I'll send you my emails and my newsletter and so forth. And if you don't want to do that, follow the research on process-based therapy and see if it isn't relevant to you, especially over the next 2 years, because it's about to get real.
Thank you very much. So I'll just open to the floor for any questions or any comments or feedback. So I would like to ask actually, based on what I'm hearing, this new app is going to be a new measurement tool to be able to kind of see how the processes actually lay across different domains, but not in the traditional normative curve. It's just that we look at them individually and all that. What are your thoughts when we apply that to a clinical setting in the future? So right now it sounds like there's a lot of theoretical base, but what happens later in the clinical? How would it actually impact or change our clinical practice with this?
Well, when we released, and I said I would show you something that's free. Unfortunately, I looked over there and realized I couldn't do it. If you get on my list or you go to ibh.com, Institute for Better Health, it's a charitable organization. I get no money for it. It's all volunteer work. We are going to release a tool that will allow you to quickly create networks like what's in that book in a matter of minutes. And we've tested and published some of these things. You show clients, hey, you say when you do this, then this happens. When you do that, then this happens. And when people see it, they say, oh, I see, because you can kind of see, they're telling you, you can see your life as to how it fits. Well, then the next step is to say, okay, now, would you be willing to just respond 2 or 3 minutes a day, let's say, and I'll send you about 20 questions that will just target these things that you've just said here are important to you, relevant to this goal that you have. And we will create an actual model based on your experience and not just your memory and your guesses about what leads to what. We've published some data, and people, when they see it's relevant to them, are willing to spend that time. And then you get 3 or 4 weeks in and you have enough data to run these idiographic statistics. And PsychFlex, which is one of 2 apps that will have MindGrapher, with a push of a button, will show you some of the things I just showed you here. And over a period of a few months, we'll show all of it. That app it costs $400 a year, but you can give it to as many people as you want. And in many parts of the world, you can charge a little bit because you're helping your clients. And what PsychFlex allows you to do is, based on what you're seeing in these networks, to send people little nudges and bumps, tiny little micro interventions, 4-minute long mindfulness exercises, or little 1-minute long suggestions about what to do about emotions or how to handle issues. And so our vision is that we can take practitioners, I know I'm at the end of my time, about finishing 30 seconds, and expand out their influence into the 24/7 world, but do it inside a process-based understanding that gives you the networks and how to target what's most important. Because as I was showing you in the data, no one-size-fits-all solution, not even ACT, is going to help everybody. The principles apply, but they apply idiographically, and you need to understand that.
Okay, we could actually spill over for a minute or two. If you don't mind, one final question from Wendy.
Oh, no, that's fine. I'm happy to do it. I'm just feeling I shouldn't steal someone's time, but I'm happy to take a question. Yeah.
This looks really exciting in terms of how we can apply this clinically. I was thinking about how do we aggregate the data then? So we've got all the individual data. Are you going to be aggregating it as well so we can see what works in terms of like if you're designing a healthcare system or if you're a therapist trying to decide what to do, can you still do that?
It's a wonderful question, and people can download their data for all of their clients and use these tools that allow some aggregation. But in addition, if individuals are willing to share fully de-identified data, so de-identified that even if you saw the database, you would not have a clue as to where that person lived, who they are, et cetera. It's just processes, outcomes, and nudges from the apps. That is going to be inside the Institute for Better Health, which is a charitable organization, science organization, protected by a world-class group of scientists, some of which you may know: Gerhard Anderson, Lance McCracken, Kelly Kerner, Baljinder Sadra, Mike Levin, current editor of JCBS. And why? Because I spent 3 years trying to build an ecosystem where we can keep the data away from Apple and Google and Big Pharma and the people who just want to milk eyeballs for money. And if we allow that to happen, and these kind of statistics are coming, it will be a train wreck, because we cannot trust information like this out there with commercial entities. So I've been trying to create a commercial app, because you need money to keep the app going, a non-commercial app that's funded by the charitable contributions, et cetera, and then de-identified data, so that scientists around the world can ask the questions that are pro-social, and Big Pharma, Apple, and Google need not apply, because the answer will be no. We're not going to give the data to you, but we'll allow you to ask questions of it. So that's the vision, and we'll see. But even if that doesn't happen, other people can imitate it and do this. I'm not trying to be grabby and say this is the only one. Once you see how it works, get on my list to be able to actually, I'll show you some videos and so forth to people who are on my list. And then within your own clinic or research team, you'll be able to apply these methods. And I know I'm going a little long, 30 seconds. What that allows you to do is, when I've modeled somebody really well, I can then look and say, hey, is Sally like Susie or like George? And you say, well, maybe. Well, then you say, well, if so, do I see anything that I would otherwise miss if I just looked at Sally, or I just look at Susie, or I just look at George? And you say, yeah, I think so. Maybe this relationship is there when I look in this larger level. I say, okay, well, let's model that in all three. If most of the people now are modeled better, we keep it. If we don't, we throw it out. So traditional statistics, the central tendency of the group is what's true, and the individual is error. In idionomic statistics, the individual is true, and the group is the source of error. It's upside down statistics. We had to make up words like idionomic even to have it. It's not normal, it's not normative. And that, I think, fits the tradition from which ACT comes, and it fits what every clinician knows in their heart, which is that person in front of them is unique, is a person. And you try to do it intuitively over sessions when you notice what gets them entangled or what lifts them up. Science ought to be on the side of the clinicians instead of lying to them systematically, which is what we've been doing in behavioral science, in my opinion. And some of this goes all the way back to the big N statisticians. And if I had time to, I would explain that some of this comes from eugenics. It comes because the statisticians were trying to figure out who was worthy to have children and who was not. That's a fact. It's dirty from the first day, from Galton forward. And it's time for us to say no and start listening to the individual human voices of those we serve.
All right. So Thank you very much. We've put the link on the chat group there, the IBH, and also your own website. I actually do read your emails, the one that you send out regularly. It's always a pleasure to read them, and yeah, I think I can say for all of us here, we'll be very much looking forward to see where this will progress and how it will carry on, and especially in the next few years, it's going to have a lot of dramatic changes.
It's gonna be fun. Thank
Yeah.
you for the opportunity to share it.
All right, thank you very much. Yeah, so this will be the end for this session. I'm just going to stop the recording for a while.